Good morning, good afternoon, good evening, and welcome to the session 5 of the Global Sepsis Alliance 2026 conference. My name is Padmini Srikantiah. It's my great pleasure to moderate this session, which is titled Neonatal Sepsis, Early Recognition, Diagnostics, and Outcomes. And we have a really wonderful panel of speakers here today to share some insights on the problem of neonatal sepsis and how we're working towards better tackling this significant public health problem. From what we will discuss is topics that start from the description of neonatal sepsis to the treatment and prevention, as well as the better diagnosis of neonatal sepsis. So I believe our first speaker today is Dr. Jeeva Sankar, who is a professor in neonatology and pediatrics at the All India Institute of Medical Sciences in New Delhi, India. And Dr. Sankar will be speaking on management of neonatal sepsis and Indian perspective. Please go ahead, Dr. Sankar.
Thank you, Dr. Padmini. Am I audible and my screen is visible?
Both are working, great.
Fine. I would briefly talk about the management of neonatal sepsis from a perspective of Indian tertiary level or a secondary level facility. Given the time constraints, I would predominantly focusing on answering two questions. How is sepsis, or the profile of sepsis is different in Indian or low middle income country settings compared to a typical high income country setting or even upper middle income country setting? And what are the implications of this difference? Are there any management implications? So I'll try to answer these two questions. How is it different and what are the implications? If you look at the incidence of sepsis, this is based on a study which we conducted almost now a decade ago. That is DENIS, that stands for Delhi Neonatal Infectious Study Collaboration. If I look at the incidence of culture-positive sepsis, as per the DENIS data, this was done in 4 level 3 hospitals in Delhi, and we enrolled about 17,000 units. And if you look at the incidence, it was at roughly 10 per 1,000 live births. And a recent data, which is from the Bernard study, which included 12 hospitals in a multi-country study, 12 hospitals from different parts, different continents, and of which one site was from India. And if you look at the Indian site from Bernard study, and there was Eastern India, and there was about 7 per 1,000 live births. This is the instance of culture-positive sepsis. Just to give a comparison of how a developed country, a high-income country, the incidence would look like. And this is on the right, we have the data from the United States, and that's national data for early onset sepsis. So we don't have the data for, I don't have the data here for late onset sepsis, but let us assume that late onset sepsis is somewhere 0.2 or 0.3. So total put together, that it's only about 0.5 to 0.8 per 1,000 live births, which is, in other words, 10-fold higher incidence of sepsis, culture-positive sepsis in India compared to a high-income country. We are dealing with a much higher number and the proportion. And what about the case fatality rate? The DENIS collaboration, we found about 48% of babies with culture-positive sepsis. There's roughly 1 in every 2, every other neonate with culture-positive sepsis died of sepsis, whereas the comparative figures from the NICHD, the National Institute of Child Health Development from the United States, and this is actually focusing only on preterm very low birth weight infants. So obviously this is likely to be an overestimate when we compare to DENIS, which includes all babies, including term babies. So even with that, discounting that, overestimation. Still, the case fatality rate is much lower in the developed country. So we are looking at roughly 2 to 3-fold higher case fatality rate in India than a high-income country. Moving on to the pathogen profile. We look at the pathogen profile of typical setting from India. This will almost look like this. This is again from the Davis collaboration. And you can see that most common organisms are Acinetobacter, Klebsiella. And if you discount coagulous negative Staphylococcus, the third common organism is E. coli. So, and put together, there is a gram-negative predominance in sepsis in India, which is different from high-income country setting, where we have usually group B streptococcus predominating, particularly early onset sepsis, and then even in late onset sepsis, you have coagulous negative Staphylococcus and other organisms, including fungus and some other negative organisms in late onset sepsis. But this total dominance of gram-negative organisms and very unusual finding of rare GBS as a causative organism is very unique to Indian setting. And antimicrobial resistance, that is the last piece of the puzzle. If you look at the antimicrobial resistance among common organisms, if you look at here on y-axis, we have the percentage of resistant bugs, and on x-axis we have different organisms and the different drugs, classes of drugs. So if you look at Klebsiella, we have more than half of Klebsiella are multi-drug resistant, and about 1/3 are resistant to carbapenems. If you look at Acinetobacter, more than 80% are multi-drug resistant, and another 80% are also carbapenem resistant. E. coli is slightly better, with about 40% multi-drug resistant, and carbapenem resistance is slightly lower. But if you look at Staph aureus and Enterococcus, more about a quarter are vancomycin resistant, and Staph aureus and coagulous negative Staphylococcus about 40 to 60% are methicillin resistant. That means you have to use vancomycin. So there's about 50 to 80% of common organisms are multi-drug resistant. So that's about level 3 hospitals. Now, what about level 2 or secondary hospitals, or what we call as district hospitals in India? This is a study which we published recently. This is a study which is multi-drug resistant in special care newborn units in district hospitals in India. That is funded by the Gates Foundation. These are 5 district hospitals across India. We in total about 6,600 units. And where we found the incidence of culture positive sepsis, including both inborn babies and babies who are referred from other hospitals, to be 3.2%. To put it in perspective, so if you look at the district hospital, that is level 2 hospitals, the incidence of culture positive sepsis is only in babies who are born in the same hospital, that is inborn neonates, 21 per 1,000 live births, which is even higher than a tertiary level hospital. But that there was a huge variation among these 5 hospitals. So roughly we can say that there's almost same or a slightly higher burden depending upon the region, or depending upon the sub-regional state level if you're looking at. But the incidence is much higher than a typical high-income country setting, even in level 2 facility. And pathogen profile is almost the same as level 3 hospital. So you have Klebsiella pneumoniae, E. coli, and Enterobacter and Serratia. Again, there's gram-negative predominance, and of course, we have Staph aureus and coagulous negative Staphylococcus. But there is a gram-negative predominance similar to what we saw in level 3 hospitals. If you look at the antimicrobial resistance, and this is level 2 hospitals, mind you. So if you look at the level 2 hospitals and the antimicrobial resistance, you have the percentage of bugs resistant to a particular antibiotic or classes of antibiotic on the y-axis, and on the x-axis we have different organisms. And if you look at 2 things, the blue bar and the green one, the blue is resistance to 3rd generation cephalosporins, and the green is resistance to carbapenem. Klebsiella more than 80% resistant to cephalosporins, and more than 50% resistant to carbapenems. That's very high resistance to even carbapenems. In E. coli, 80% resistance to cephalosporins, And Enterobacter, again, it's the same, about 40% are resistant to carbapenems. And Acinetobacter, 3/4 of Acinetobacter isolates are resistant to carbapenems, even in a district hospital or a level 2 hospital. Again, there was variation among the hospitals, but largely there is high resistance to third generation cephalosporins and moderate resistance to carbapenems. So there's no difference, much difference between level 2 and level 3. So to summarize, the issues are there is in India, we have high burden and high case fatality rate. There's a gram-negative predominance and high antimicrobial resistance. Now, what are the implications of these findings? Now, if you look at the antibiotic regimes, this is the WHO aware, the classification of access watch and reserve antibiotics. And this is the antibiotic guidelines by World Health Organization. And if you look at neonatal sepsis, the first choice recommended by WHO is ampicillin and gentamicin, ampicillin plus gentamicin. And the second choice, the second line antibiotics is the third generation cephalosporin, either cefotaxime or ceftriaxone, combined with amikacin. And that's a recommended regimen by the World Health Organization. And if you look at the NICE guidelines, that is National Institute for Health and Care Excellence from United Kingdom, again, they recommend benzylpenicillin with gentamicin for early onset sepsis, and flucloxacillin, that is cloxacillin or plus gentamicin for late onset sepsis. Now, what about these antibiotics in India? If you use these antibiotics, what coverage you would achieve? And this the study, which was published in JAMA Electropopan just a few years ago, this examined the coverage of the common used 3 antibiotic regimes in different Asian countries. And this is on y-axis we have the isolates covered by a particular regime, and on x-axis we have different countries. Now, if you look at India, these are the number of isolates are about 5,000 isolates. So we have a large number of isolates. And if you look at these 3, you can see that this the amber color one is third generation cephalosporins. So only 30% of all the isolates actually are covered by this third generation cephalosporin, which is second line antibiotic by WHO. And if you look at aminopenicillin and gentamicin, which is the first line, is about 40% coverage. About 60% are resistant. That means. And if you look at meropenem, it's about 2/3 are covered by carbapenem or meropenem therapy. So the WHO first line and second line regimes are unlikely to work in most settings in India. And this is further reinforced by a study published just a few months ago. This is a study comparing different antibiotic regimes in both neonates and children. Largely, the findings are the same. If you look at third generation cephalosporins, it's only about 30% in neonatal sepsis. Only about 30% are covered by of the isolates covered by third generation cephalosporins. And for even aminopenicillin, it's about 1/4. And carbapenems is slightly higher. But this is all countries put together. We do not have data specifically for India. But largely, it's predominantly the isolates are predominantly from India and China. So we can say that there is a high resistance to aminopenicillins and third generation cephalosporins. So the first line and the second line regime recommended by the World Health Organization or by guidelines from high-income country are not applicable definitely in Indian settings. So we need to frame an antibiotic policy, and that to every unit and every region should have an antibiotic policy depending upon the antibiotic susceptibility pattern in that particular region. So we have recently developed a tool, and we are currently validating it as an individual antibiotic policy broadly with these principles, which is developed by AIMS with the help of IIIT Delhi. And these are the broad guidelines. So trying to cover 2/3 to 70% by first line and about 90% by second line antibiotic, and with the data for 6 to 12 months. And if the particular unit uploads their data in a CSV, in Excel or CSV format, then they can analyze and they will get a local antibiotic policy. And we plan to test this in different settings, and then we will be able to implement it for use in settings across the country. The second part which we need to deal with to reduce this antimicrobial resistance and to have a better coverage of the bugs is to have accurate diagnosis. So if you look at blood culture, it's only about positive. It's positive only about 40% of all babies with suspected sepsis. But again, this is in research setting. In a clinical setting, it will be much lower. It's about only 10 to 20% of cases actually turn out to be culture positive sepsis, and the remaining are labeled as culture negative sepsis. We need something else to accurately and reliably diagnose sepsis. And these could vary from hematological parameters to acute phase reactants and cytokines. But unfortunately, none of them are reliable. What we need is a reliable point of care test, which can accurately and rapidly diagnose sepsis, thereby preventing the misuse of antibiotics and therefore reduce antimicrobial resistance. Most high-income countries, they use clinical prediction tool, or particularly for early onset sepsis calculator. But again, that might not be applicable in Indian setting because of one high incidence of sepsis and the rare occurrence of group B streptococcal sepsis. And therefore, we developed this clinical prediction model based on a machine learning tool, based on the Dennis data, and we are also developing based on the Deschutes Hospital data for different clinical prediction model for different settings. And this is the model. This is how it's the best application, which has 23 to 20 parameters depending upon the setting, and it takes about 2 minutes to fill. And if you once you have the inputs, then it will give the prediction whether it is sepsis likely to be positive or negative, based on which you can start antibiotics or you can withhold antibiotics. And once the culture comes out, based on the clinical course, you can start or you can stop antibiotics. We are planning to validate this tool for better prediction of early onset sepsis in a multi-site study. And of course, the last part of my talk is on antibiotic stewardship program, without which it will be very difficult to manage the spiraling antimicrobial resistance in the country. We need a tool which is easy to implement, which is demystified, and it can be implemented even at a level 2 facility in India. We need a simple tool for implementation. So these are the management implications given the profile and the high burden and high antimicrobial resistance in India. I will stop here. Thank you.
Thank you very much, Dr. Sankar, for a really great presentation and outlining, of course, the stark situation of neonatal sepsis in the subcontinent in India. We are running a couple minutes behind time, so I'm going to move us on to the next presentation, which will take us to the African continent and to Dr. Angela Dramowski, who is from Stellenbosch University and a pediatrician and the head of the clinical unit at Tygerberg Hospital, who will speak about the experience in Africa on neonatal sepsis and the impact of AMR in this setting. Over to you, Angela.
Thank you so much, Padmini, and thank you to the Global Sepsis Alliance for the invitation to speak today. I see you are not seeing my slides, so let me just stop sharing and share again. Super. So I will be taking you to the African continent, where I'll be sharing some disturbingly similar experiences to those you've heard from Jeeva about the impact of antimicrobial resistance on neonatal sepsis. Many of you are aware that 1 million newborns die on the African continent in their first 28 days of life. And although other parts of the world have seen major declines in neonatal mortality, this has not occurred in Africa. And infections remain among the top 3 leading causes of neonatal death, and increasingly are demonstrated as on the causal pathway to death in particularly preterm infants. The need in Africa is growing, and we know that by 2050, 40% of global births will occur on this continent, at the same time increasing pressure on already overcrowded maternity and neonatal facilities. And it's increasingly clear that although we need to work across the pathway from preconception to pregnancy, labor, and postnatal care, in neonatal units, our focus should be the care of small and sick newborns. In neonatal units where major improvements in survival, particularly early survival, have occurred, disturbingly late survival rates have declined, with sepsis mortality rates doubling in neonatal units in Uganda. Similarly, in Chris Hani Baragwanath Hospital, the largest neonatal unit in South Africa, mortality study revealed that up to 70% of deaths that were previously thought to be due to prematurity had infections with antimicrobial resistant pathogens on the causal pathway to death. These infections do not affect single babies or families. They become large, difficult to control and difficult to treat outbreaks that are all over the press and social media, and making it very difficult to prevent these neonatal sepsis occurrences. Why are babies vulnerable to infections? We're well aware that they have challenges with immature immune systems, skin and gut barriers that are vulnerable, particularly in preterm infants. There are lots of care-related factors that put neonates at risk, like high rates of antibiotic use, indwelling devices, difficult environments where we have to share equipment in resource-limited settings with suboptimal cleaning and weak IPC programs, and then crowded units, many caregivers, frequent handling of vulnerable infants. So how is antimicrobial resistance acquired in the first place? Well, in the pregnant woman, there are multiple factors, from water sanitation and hygiene, so contaminated water supplies, contact and consumption of AMR contaminated food sources, unregulated antibiotic use, and then in the very hospitals where the babies are born, mums are met with contaminated surfaces, hands, and equipment at the time of delivery. As mums become colonized with these antimicrobial resistant pathogens, they can be vertically transmitted at the time of birth, and then in vulnerable babies, they can proceed from just mere colonization to infection, sepsis, and death in a matter of hours and days. Clearly, the concept of neonatal sepsis for many years has been a dichotomy between vertical transmission, causing early onset neonatal sepsis, and horizontal transmission, thought to cause healthcare-associated infection. But the boundaries are now very blurred as we see babies on the first day of life acquiring pathogens that are typically hospital-acquired and antimicrobial resistance. The scale of the problem is massive. And as Jeeva highlighted, gram-negative bacteria, both for early onset and healthcare-associated infections, are the main pathogens. And the challenge with that is that gram-negative bacteria harbor much higher rates of antimicrobial resistance and are listed in the critical priority pathogens by the World Health Organization. Data from the antimicrobial resistance collaborators that you see in the middle of the screen, those green bars, show that the problem is predominant in Africa. And as Jeeva mentioned, the problems are mostly in Klebsiella pneumoniae, but also E. coli and Acinetobacter baumannii, amongst other gram-negatives. Similarly, Jeeva shared with you some of these large-scale studies conducted across the globe that demonstrated really disturbing rates of antimicrobial resistance amongst both early onset and healthcare-associated bloodstream infections in neonates. And really what this has led to is a mismatch between neonatal sepsis guidelines, which largely have relied on data from high-income country neonates with bloodstream infections. And in a survey conducted just last year across African neonatal units and their healthcare workers, what we demonstrated is that clinicians follow guidelines religiously, but increasingly the pathogens that they are trying to treat are not covered by these same guidelines. And even when clinicians are very aware that these guidelines need to change, they don't have local tools, laboratory support, and expertise, or even cost to be able to afford some of the newer antibiotics needed to treat these very resistant pathogens. And the overall impact of antibiotic resistance is to drive even poorer outcomes than those you heard from Jeeva. So in our setting, 1 in 3 babies with bloodstream infection will die. And what we see when there is a bug-drug mismatch, where the empiric therapy does not cover the pathogen or its resistance profile, is a tripling of the odds of mortality in babies who receive discordant therapy. This impact is not the same depending on level of care. So if you just look at the little red diamonds, those are tertiary centers in South Africa, and the 3 most commonly used antibiotic regimens for early onset sepsis and the latter 2 for healthcare associated infection. You can see coverage is really poor, 50% for ampicillin and gentamicin for early onset sepsis. So we have lots of challenges with antimicrobial resistance, but these are also opportunities to do better. And so despite all the doom and gloom that we're sharing with you today, I just want to highlight some of the innovations that are happening in this space. So Jeeva beautifully outlined all the diagnostic difficulties that we face, and also the fact that we have really limited treatment options, with only 4 new antibiotics being registered for neonates since 2000. But at the same time, across the globe, people are doing really important work to improve options for diagnosis of both antimicrobial resistance in a more rapid fashion, for detecting outbreaks using new metrics that don't rely necessarily on blood culture, and also in development of clinical prediction scores so that we can use some bedside available and point of care tests to better define which neonates need immediate treatment. At the same time, Julia in the next talk is going to highlight some really exciting new neonatal trial designs and consortia that have been developed in the last few years, as well as a pipeline of new and repurposed antibiotic agents that may be possible replacements for the currently recommended empiric therapies. I think although Jeeva presented a lot of data from India, the African continent really has a paucity of population level data on neonatal sepsis incidence. And this is on the continent with some of the highest burdens of neonatal infection. We'll hear from another speaker later on about lots of barriers around the definition of neonatal sepsis, and how this lack of harmonized definitions and other ethical and hospital barriers to sharing of data are really hampering our progress in this space. And currently, global AMR surveillance is particularly lacking in stratification of population. So we're not able to identify from all the Klebsiella sepsis how many of these occur in neonates. And this is a very important population to bring out. At the same time, across the African continent, there are lots of exciting partnerships using clinical decision support tools at the bedside to drive better care of neonates with sepsis, and similarly to use data for quality improvement purposes in individual hospitals and neonatal units. You've heard from Jeeva about the challenges in preventing infection. So we know that mums on the African continent are more highly colonized with antimicrobial resistant pathogens with increased risk of vertical transmission. And we also know that the healthcare facility environment is suboptimal with lack of appropriate water sanitation and hygiene, leading to higher risk of healthcare associated infection. And some really well-known interventions are making a big comeback. So immediate KMC or skin-to-skin care is really effective in preventing sepsis. In terms of infection control, we are learning that family-centered newborn care and infection control makes a massive difference to infection rates, data coming out of Botswana. And we look forward to a future of maternal vaccination to prevent neonatal sepsis, with the Group B streptococcus vaccine hopefully being nearest on the horizon, and hopefully through many collaborations to identify potential serotypes that would be included in a future Klebsiella vaccine, we will be some steps closer to being able to prevent the pathogen that causes over 50% of neonatal sepsis globally. Jeeva also mentioned the really important aspect of antimicrobial stewardship. It is not a simple cut and paste from a high-income country setting to doing stewardship in low-resource settings. It really requires even more team-based, multidisciplinary management to achieve and drive change and to sustain change. And this will be even more important as we introduce the new antibiotics and regimens that Julia will speak to you about now. So in closing, it is going to be an uphill battle, but some of the important high priority interventions that we should be focusing on to improve outcomes from neonatal sepsis and antimicrobial resistant infections are strengthening of general good quality care and infection prevention programs for maternal newborn facilities. We need better diagnostics, both for neonatal sepsis and rapid identification of antimicrobial resistance. We need to do better in terms of surveillance, both for understanding the scale, burden, and impact of disease, but also to inform our antibiotic treatment guidelines. We should be investing much more to accelerate antibiotic discovery, open trials to neonates, and ensure access that is equitable to neonatal units across the globe. And lastly, we need to promote antimicrobial stewardship to protect the new drugs that are developed. And all of this will require strategic global partnerships, advocacy, policies, funding, and capacity development to sustain. And no doubt we will get there one step at a time. And I'd like to thank the many, many partners that are working across the globe on the issue of neonatal sepsis. Thank you for your time.
Thank you so much, Angela. That was a really wonderful overview and actually in-depth discussion of the challenges of neonatal sepsis in the African continent. I wonder, I know we're a couple minutes behind, but I would like to take a moderator's prerogative and ask you one question, which is related to the family-centered infection prevention control. I think, there are many challenges, and Julia in the next talk will be talking about treatment, and Quique after that on diagnostics. But prevention, of course, is one of the most important ways that we can try to reduce the mortality from neonatal sepsis. And I wonder if you could speak just a minute on the family-centered IPC and what impact has been seen from that in Botswana.
So essentially, they took mothers as partners in the care of their newborns, empowering them to be at the bedside, advocating for best care for their babies, reminding healthcare workers to do hand hygiene, really instituting kangaroo mother care to its optimal impact, assisting even with cleaning of the immediate healthcare environment, the bassinet for their baby, producing breast milk, ensuring their baby obtains breast milk, and really just improving awareness and shared learning between healthcare workers and mothers who are the predominant primary caregivers in the space of the neonatal unit. And what they saw was reduced frequency of outbreaks and a sustained reduction over time in invasive bloodstream infections on their newborn care unit. Over.
Thanks, Angela. I think, really interesting findings from Botswana. And I think one of the things that we think about with infection prevention control is the conflicting messages that families and patients often hear about their potential role as someone who can be an introducer of pathogens on the ward, and it's heartening to hear about their potential role as someone who can help to prevent infections on the ward. And I think learning more about and testing more of these potential interventions is going to be important. We will switch now to talk, and we've heard from both Jeeva as well as Angela on really important and stark and sobering data, both from the South Asian subcontinent as well as the Indian subcontinent, as well as sub-Saharan Africa, on the role of neonatal sepsis in contributing to neonatal mortality and the challenges with treatment. And Angela referred also to the now some very systematic and impressive large-scale trials that are looking at what ways we can bring better data to guide treatment options for neonatal sepsis in these lower resource settings. So it's my pleasure to turn over to Professor Julia Bielicki, who is both affiliated with City St. George's in the UK, as well as with the University of Basel in Switzerland, and has been an important leader in the GARD-P neonatal sepsis trial, NeoSep1. So I'll turn over to you, Julia, to speak more about determining the most effective treatments for neonatal
Wonderful.
sepsis.
Thank you, Padmini. Can you see my slides? Can I just confirm? Yeah, you can?
Yes, we can.
Okay,
Yes.
Let's see whether they're moving. Yes, they are. Wonderful.
Indeed.
So I'm going to try and be as short as I can, although it's really difficult with this trial, as some of the people on the panel will appreciate, having thought about it together with me for quite some time. But let's see how we get on. So just to kind of ease you into the topic, I'm going to pick up some of the points that have already been made, but I'll keep myself short. In order to plan a trial of neonatal sepsis treatment, it's really important to understand what the current epidemiology is. And you've already seen some of the data out of India and out of Africa shared by the previous two speakers. But in order to cover sort of more ground, we looked at this in the NeoOBS study. This was a cohort study of more than 3,200 babies with clinically identified neonatal sepsis in 19 sites in 11 countries, and we looked at how they were being managed and what their outcomes were. And the first thing that you see is that you have a wide variation in antibiotic use. And maybe this won't surprise you based on what we've already heard, with over 206 different regimens started in these 3,200 and some babies. And you can also see that there is a strong side effect for this, where there's a relatively high use of what some of us would consider second line or second choice antibiotics used empirically in some sites, whereas other sites are still using more conservative regimens. And then you also see that while many babies are initiated on a treatment and then stop, and some sadly die, there is actually quite a lot of switching going on, so that 25% of infants in this cohort study switched to different antibiotics, often within the first few days of treatment, and often as a measure to escalate treatment, so because they weren't getting better rather than as a measure of de-escalation. And you can see why that is, and that is the data that you've already seen. And essentially, this approach is fairly rational, I would say, on the side of the clinicians, because they're moving away from regimens that have suboptimal coverage, despite being recommended in international guidelines. So that forms the basis of the NeoSep trial. And then taking these data, you ask yourself, how are we going to design this trial to answer the question about what should or should not be used for empiric treatment of newborns internationally? So I want to just talk you through some of the primary assumptions underpinning this trial. And in order for you to understand how we got there, it is important that we understand how typically an RCT would be set up. So a typical one-to-one randomized control trial is one where there is a standard of care regimen, which new regimens or test regimens would be compared to. And that isn't the case in NeoSep, in the neonatal sepsis space, as I've just shown you. And in a standard trial paradigm, we can only investigate really whether the new or test regimen is definitely better than this standard of care, and you basically have this goal of showing this with a high probability, and that's your p less than 0.05, which we also cannot do because we don't have a standard of care. And you would assume that switching from standard of care to test is relatively low, and that's the basis that underpins intention to treat principles, which is not the case. So even if we ignore this problem of the lack of a standard of care that really undermines a typical trial approach, then if you consider what would happen if we chose a classical MAMS design, so looking at lots of regimens that maybe some people would be interested in, we would be comparing those against the standard of care. And that means that any baby in such a trial would have to, it would have to be acceptable for them to be randomized between all the options. That's the principle of a multi-arm, multi-stage design. So if you think about who one of us would include in such a trial to be randomized to ampicillin, gentamicin versus meropenem plus maybe some other options, it's probably a baby who just doesn't need antibiotic treatment at all. And that doesn't help us because we want to know what we should be treating babies with who absolutely do need antibiotics. So you cannot run a standard RCT because the results would not be generalizable to the wider population of neonates. So instead, what we've selected to do is to use a very sophisticated and novel approach where we are combining two types of trial. One is called a practical. It's a design where you can basically randomize participants between options when there is no standard of care because you have a personalized selection of regimens to randomize between, and you use a specific approach to analyze those. And a SMART, and that addresses our frequent switching problem, where you have a second randomization for babies who aren't doing well, and that's shown here. My slides seem to have got compressed, so apologies if you can't see what it says below, but it's essentially what it says is what we walk through in the next slides, and that is that sides actually help us determine which range of first and second line antibiotic regimens from a master list is relevant to them. And so that determines their randomization lists. So basically, just to highlight again the very specific features of the practical, this is a design where you simply have no SOC. And so each patient is randomized between a subset of regimens. And you can't do this pairwise comparison, and you instead test multiple intervention arms against each other so that you can use all the direct and indirect comparative data from this trial. So these are our regimens of interest. You can see that we have included the WHO regimens. We have included some other commonly prescribed regimens that we identified from NeoObs, and we also have some novel combinations of not so novel antibiotics. They're really rather old, and they have a neonatal license, but they haven't been used for the treatment of neonatal sepsis widely, or have only been used in very specific countries like Flomoxef, which is actually a cephalosporin akin to latamoxef, in case this is familiar to anyone. And so this is how the NeoSep trial then works. Each site selects from this list suitable randomizations, and they may depend on the local microbiology. So lists, for example, perhaps in one Indian site might look different to another Indian site, and we have Indian sites in NeoSep. They would also depend on what current antibiotics are being used, because you'd want a comparison against them, and maybe subpopulations at the site that you use different treatment approaches for to others. And then for second line, it's a little bit less interactive because this is largely determined by what baby was randomized to in the first randomization. So here are some examples. So this is one of the lists that has been selected, where you have a low suspicion of meningitis, and this site clearly is an ampicillin gentamicin using site, and this would be the randomization for this baby. And here you have some examples for a late onset sepsis case. And we have several of these lists. In fact, there's 6 of them. And you can see that the novel regimens, where we are in the greatest need of generating data because we want to have confidence in whether they should be used at all, are included on all of these lists. So I'm not going to go through exactly the mechanics of the trial, but just to give you a little bit of a flavor of how we will analyze this, because this is how the community, will be using these data hopefully in the future. So the primary aim is to produce a ranking of the treatments that can be used to guide decision making, rather than the typical pairwise comparison that we have in an RCT, a standard RCT. So methods will respect the randomization. We will compare evidence on treatment differences from participants within the same randomization list, but we will use both direct evidence and indirect evidence by pooling evidence across patterns. And that's basically very similar to meta-analysis. So the trial results will answer a very specific question, which is out of the X acceptable regimens for this patient, which will provide, which will be one of the ones that will provide the greatest chances of success. And so it's not the best treatment, but it's basically one of the best treatments. And you literally produce a ranking for that. And what it helps you to do is to really avoid the worst regimen. So neonatal sepsis antibiotic trials need this new approach because there's no standard of care, and there's many regimens that are used commonly without any evidence base. And this is a trial that will allow us to answer that question. And even though there are costs to this trial, because there is no free lunch, there ain't no such thing as a free lunch, is what Sarah always says. So you have a cost in terms of precision. It is actually the best way to answer a really important question where there is a very high burden, particularly also from resistant infection. So with that, I will close, and I hope I stuck as much to my 10 minutes as I could. Thank you, Padmini.
Fantastic, Julia. Thank you so much. I know it's a lot to cover in a short period of time and a complex trial. I'm going to ask you just two short questions. Hopefully we can have quick answers as we
Sure, I will try.
Along. So the first is related to carbapenem-resistant organisms and how you envision this trial providing data on treatment for carbapenem-resistant organisms, knowing that it includes meropenem, but not other options that go beyond carbapenems.
So there is a short answer to that question, and essentially it doesn't. So there are provisions for babies who are found to have a carbapenem-resistant organism also to be switched to clinician-selected therapy. But this is really a trial that targets populations where there's a lot of ESBL producing gram-negatives.
Yeah, and I think that's a really important distinction to make and recognize, of course, that particularly in the data that Jeeva presented from India, that carbapenem resistance is an enormous problem in the South Asian context. And hopefully as this trial produces data, there will be a platform that will enable evaluation of treatment options for carbapenem resistance as well. The second question is one that I think I spent time thinking about, which is right now, of course, Jeeva and Angela both presented on the AWARE guidelines and what is prescribed as first-line and second-line treatment for neonatal sepsis in a currently what is a one-size-fits-all approach. And I think one of the messages that I hear from the NeoSep trial is one size doesn't necessarily fit all. And so how do you envision this being translated into guidelines? I think the practitioners online might appreciate hearing how that might be translated.
And again, I will keep my answer brief. I don't think we know yet, but we are actually working now on a sort of what would guidance based on this kind of design look like. And we're not working on this alone. We're working on this with colleagues from adult sepsis world who are also using this design, because it is true to say that it doesn't fit Grade Plus or any of the typical guideline development tools. So we will need to think about how to make this something that is easy to comprehend and use for the community.
Great. And we do have one question from the chat, which is about, and I think an important question, availability of antibiotics, both in the context of this trial. Does this trial avail the sites of the antibiotics? And then what does it mean sort of going forward?
Yes. So this is a point that is also, I think is actually critical. We wouldn't be doing a trial when we didn't think that we were able to then make the antibiotics available. It's also why certain antibiotics maybe are not on our master list. So the sponsor of this trial is GARD-P, and they are working again in parallel to us implementing the trial on the pathways towards then making these antibiotics available, at least in the trial countries, but hopefully more broadly, if indeed we demonstrate them to be amongst the better options, which is something, of course, that in any trial you don't know until you've completed the trial.
Wonderful. Thanks so much, Julia.
Thank you.
We should move on to the next talk. And I think we heard in both the talks from Jeeva Sankar from India and Angela Dramowski from South Africa that there is a desire to have better recognition, earlier recognition and detection, and ideally diagnostics for neonatal sepsis. So to talk about the approaches to improving the risk stratification of neonates that may help to identify neonates at greater risk of sepsis and thus improve their management and survival, we'll turn to Dr. Quique Bassat, who is a research professor and the director of the Barcelona Institute for Global Health. He has been working in pediatrics and child survival for many years, and we'll be speaking today on prognostic biomarkers to risk stratify sick neonates and improve their management and survival. It's a pleasure to have you, Quique. Over to you.
Many thanks, Padmini. Very happy to be here today. Angela already mentioned in her introduction where child mortality clusters and why neonatal mortality is becoming increasingly important. No, we've seen very fast declines in the last 3 decades of child mortality, and particularly under 5 mortality, but the declines in neonatal mortality have been proportionally much slower, and therefore the share of mortality attributed to neonates is becoming increasingly important. And also where the problem of child mortality and neonatal mortality is essentially occurring. And we know today that 8 in 10 global deaths in children and even in young adolescents and adults are already taking place in sub-Saharan Africa and Southern Asia. But the population growth or the demographic explosion that Africa is witnessing leads to that the share of death among children will become increasingly important in the African continent. We know that neonatal mortality accounts for about 2.3 million deaths every year, and we know that neonatal sepsis has an important share of this large number. So today I'm gonna speak on a different angle, and we pediatricians have always been obsessed with diagnosis, and we are obsessed with figuring out whether something is caused by a bacteria or a virus or the precise etiology, because we think that is gonna give us the key on the adequate treatment. And I would like to defend today a change in the paradigm and trying to change the paradigm of triage from diagnosis to prognosis, and I think you will understand after my talk. So what we know today, and I'm speaking widely in children, not only in the neonate, but the problem gets exacerbated in the neonate, is that defective triage of sick children leads to preventable mortality. We know that acute infections are a leading reason for medical consultations globally. But we know that only a very small proportion, often around 1% of all those cases, are really the ones we need to focus on, because are really the ones that have the potential to cause a life-threatening disease or eventually death. And we have many triaging tools that we use routinely, particularly in high-income settings, but all over the world. We use biomarkers for the quick triage based on the identification of likely bacterial etiology, like C-reactive protein or procalcitonin. We have all the clinical scores and algorithms. But we know that these triage methods that are routinely used today are often inefficient, are often expensive, are often misdirected, and may take a long time to provide results, are slow, or may require high expertise or infrastructure. And the reality is that in those places where child mortality and specifically neonatal mortality cluster, many of those triaging tools are often unavailable. We also know that defective triage leads to misallocation of resources, and that's why the concept of triage is becoming increasingly important. We also have a bottleneck at discharge. We know this for pediatric wards, but this is an even increasingly important problem in the neonatal wards, and particularly for theoretically healthy neonates. We know that in many African maternities, mothers deliver, and a few hours later, mothers go home with the kids. And that doesn't even give us time to take appropriate decisions in terms of how likely this neonate is going to remain healthy and not become sick. So, as a summary, we actually need better tools for the risk stratification of sick patients, and the key questions that we need to address are questions related to disease severity and prognosis, because those are the ones that are going to help us guide clinical decision making. And once we have taken this initial decision, then we will care more about the etiology. So the three key questions that I think we need to answer is who is or will likely become critically ill and needs referral and or admission, who will benefit from prioritization for intensive care or high-cost therapeutics, and we've seen in the previous talks that we often don't have availability, many of those high-cost therapeutics, and then finally, who can safely be discharged from hospital and who will benefit from a post-discharge follow-up. So there is a strategy, and I often like to show this crystal ball because this strategy looks very much like a crystal ball, and what we would like to have is a test that can be done at the bedside of the patient or near the newborn, that is quick, that only requires a simple sample, being a drop of blood or an even less invasive sample, that is battery powered, that is user-friendly, that is quantitative, and that the result of this test, irrespective of what this test measures, can help us classify the patient that we have in front of us according to the WHO recommended traffic light system. Being green, low risk, and the patient can be discharged, or yellow or red, moderate to high risk, the patient needs to be prioritized, or even we have to run and take him to the neonatal intensive care unit. So there is a science supporting this strategy, or the feasibility of this strategy rather, which relates to host response prognostic biomarkers. We know that many life-threatening infections cause dysregulated host responses, which ultimately can lead to multi-organ failure. We also know, and that's a very important concept, not only for neonates, but for the larger age groups, that different types of pathogens share common pathways of injury, and therefore that these are pathogen agnostic mechanisms of disease, and they should work similarly well for a bacteria that it causes very severe disease, or for a parasite, or for a virus that causes very severe disease. And we know that immune and endothelial activation lay upstream of endothelial destabilization, microvascular leak, multi-organ dysfunction, and eventually death. Therefore, these pathways have emerged as crucial players in severe and fatal infection pathogenesis. I've chosen a few examples of some of those markers. My personally preferred one is STREM1, is the one we are working with in most of the time. It's a highly performing prognostic biomarker across a variety of different infectious diseases. And I've chosen here a few examples of neonatal sepsis, bacterial etiology, parasite, malaria, viral disease, even COVID in adults. And it systematically shows whenever you try and look at its prognostic capacity, it always comes as a very good predictor of what is going to happen, like the crystal ball that I was showing before. These are a few of our own data. On the right side of the figure, the prognostic performance of STREM1 compared to other markers, host response biomarkers, including CRP and procalcitonin, and you can see that the areas under the curve of STREM1 to predict mortality by day 28 after the first measurement. So you measure on first encounter and it predicts mortality up until day 28. The area under the curve is much better than any of the other ones. And importantly, it adds prognostic performance when you actually add it to typical clinical scores. So the addition of the measurement of this marker improves the performance of the typical clinical scores, and it outperforms other classical markers of severity, like, for example, lactate. So from this crazy strategy or idea of a strategy, we needed to go to a triable strategy, and we were lucky to get funded by the European Union in 2022. The project that we call the Equilibrist. This is enhancing children's lives with biomarkers for risk stratification and triage. This is not a neonatal trial. This is a pediatric trial, children 1 month to 5 years of age, with 15 partners, and with 2 main work streams. The first one aims to design and validate a device that actually can do what I was showing you in the strategy figure, that helps us risk stratify at first encounter patients. And the second work stream is all the clinical trials and sub-studies that are required to assess the impact of the introduction of the device for risk stratification purposes to enhance outcomes, guide management, and save costs. I will not bore you with the details of that pediatric trial. I just want to show you how the device looks like. We are working with a startup here in Barcelona, producing this device that looks conceptually like a glucometer. It measures the STREM1, but it can measure other analytes, because the round thing that you can see in the picture is the cartridge that you use for the specific marker you are interested to measure. And the science behind this prototype is a magneto-actuated device with an electrochemical readout. So enough of non-neonates, and this is the neonatal specific project. It's called Acrobat, and it's specifically targeting the newborn. This again is going to be performed as funded by the EDCTP program in the European Union, with partners in Europe and 4 strong partners in Africa, including Mozambique, Uganda, Ethiopia, Gabon, and a commercialization partner in Nigeria. And the aims and the objectives of this Acrobat project that is just starting now is to advance the valorization of XTREM, which is how we've called our rapid prognostic test, which is based on the quantification at the patient's bedside of the levels of STREM1 to risk stratify all-cause sick newborns. And that's important, all-cause, not specifically neonatal sepsis newborns, any sick newborn, in hospitals of 4 African countries. And we have different specific objectives, including the determination of the prognostic performance of the XTREM device, the comparison of STREM1 with other biomarkers and algorithms to demonstrate the competitive advantage, the usability, the acceptability, the feasibility in a relevant environment. And we're thinking and discussing urban and rural African settings, to model the cost effectiveness and health impact of the device, to work on the industrial prototype, to obtain the CE mark and identify the regulatory pathway, and to develop a business plan. These are the procedures that we will do in our sick cohort. We have a sick cohort and a healthy cohort. We are ambitious. We want to recruit 4,000 sick newborns across the 4 African countries and follow them for 90 days. And determine the levels of the biomarkers at different time points, so we can also establish longitudinally the kinetics of those markers. We have lots of information about the level at first encounter and how well it predicts, but we have much less information about how the kinetics work, how quickly the biomarker levels decrease in response to treatment or increase when there is an adverse event approaching. So this is what we're going to do with sick newborns up until day 90. And we have also 10% additional recruitment of healthy neonates, where we're going to repeat most of the determinations to have a good idea and a good comparison. I don't want to go much longer. I think this is conceptually something very different to what we've normally been talking about. We've always tried to focus on identifying the specific diagnosis. We're also going to be doing this, of course, here. But the important thing here is how can we not miss a newborn that is likely to progress rapidly or more slowly towards an adverse outcome, because if we prioritize those and we don't miss those, those are the ones that will allow us to intervene. And also, how can we more quickly identify those at higher risk so that we can prioritize the resources we have. So in conclusion, severe neonatal infections remain a major cause of death in children globally. Comparatively to other syndromes, we are still lagging behind in terms of better tools for its initial diagnosis and triage, management and prevention. The holy grail of good etiological approaches is still elusive. And more importantly, ascertaining the underlying etiology does not guarantee the possibility of failing to recognize its potential severity. We know that in the field of pneumonia, for example, where even if we have a likely bacterial pneumonia, in some cases, we are not recognizing the severity, and we should not only focus on the underlying etiology. Host biomarkers of immune and endothelial activation offer a good opportunity to predict outcome and obviously need to be further explored. And there is much less information about their prognostic performance than comparatively to older children. And that's why we want to focus in the newborn, and we want to focus in all-cause severity, all-cause disease. And with a point-of-care approach, of course, to quantify those, we are one step closer to comprehensively assess the potential transformative impact on triage and child survival that these markers can have in the future. For the older child, we have strategies, and we have we have clinical trials ongoing to help us introduce the test and evaluate how much this can change child survival. For the neonates at the moment, we are just generating evidence of its prognostic performance that will allow us in a next step to design better strategies. And I'll leave it here. Thank you very much.
Thank you so much, Quique. Really fascinating talk, and exciting to hear about the progress on 2 large-scale clinical trials, and really sort of shifting the question from specific etiology to really looking at the host and looking at the infant, and seeing what markers might help us in identifying those at greatest risk of poor outcomes. We have a question in the chat regarding the cost of the device, and it might be premature. It sounds like it's still in trial format, but I wonder if you can very briefly comment on it.
Yeah, of course, this is a prototype, so this is not yet commercialized, but obviously it has been designed specifically for low-income settings. So the target price of the cartridge has to be less than $5 at the moment, and obviously with the intention of bringing it down to as close as $1 as possible. At the moment, that is the target for the cartridge. For the device itself, we are using a platform that was already used for other purposes. So the production of the platform itself, of the thing that looks like a glucometer, it should also be relatively cheap. But at the moment, it's still a prototype, so we don't have a figure yet.
Thanks so much, Quique.
Can I say something, Padmini?
Yeah.
Forgive me for
Please.
that, because I saw Julia in the internal chat ask about opportunities. Julia is running a massive trial, as we heard, and we are all in favor of sharing opportunities. So we are more than welcome to explore the possibility of including the measurement of those markers in big trials like the one Julia is running. So I'm more than happy to explore future collaborations. We've done this with adult studies, we've done this with older children studies. We've become a little bit a source of evaluation of these markers in ongoing efforts.
Fantastic. No, I think that sort of collaboration is definitely necessary. And I think one of the things that you mentioned, which takes us really nicely to the next talk also, is the idea of looking at mortality overall and all-cause mortality, or not necessarily specifically speaking of sepsis or infection. And so we're obviously all focused on making sure that we're able to contribute towards the reduction of neonatal mortality, whether due to sepsis or otherwise. And we know that sepsis and infection is an important contributor to that. So I'm going to take this opportunity to go to our final talk in this session, which is from Dr. Eleanor Molloy, who is from the Trinity College Dublin. And she will be speaking, and I think this talk is actually a recorded talk because Eleanor is not able to join live today, but on the difficulty in finding a universal definition of neonatal sepsis. And I think that Quique's points about neonatal ill neonates and those who are at greatest risk of poor outcomes and identifying ways to come up with prognostic indicators to see which infants are at greatest risk for poor outcomes and how those outcomes can be prevented is ultimately our broader goal. And so I will turn now to our AV folks who will kindly put on the video that Eleanor has pre-recorded on her talk, The Difficulty in Finding a Universal Definition of Neonatal Sepsis.
So, hi everyone. I'm delighted to have the opportunity to present at this amazing Congress today. My name's Eleanor Molloy and I'm a neonatologist. I'm based in Dublin in Ireland, and I'm also a professor of pediatrics in Trinity College in Dublin. My title is The Difficulty of Finding a Universal Definition of Neonatal Sepsis. I think this is a group I don't have to tell about how we have a huge issue with sepsis internationally, and the estimates have had to double recently because we realized that we weren't counting all the deaths from sepsis. And of course, children, and especially those in lower middle income countries, are hit the hardest. And we can see these figures of over 6 million newborn and small children every year in developing countries. And as well as that, we know that there are other long-term sequelae other than death, as in there's neurodevelopmental and other multi-organ issues. And even in our tiny preterm babies, even if they have a mild coag-negative staphylococcal sepsis, something that's a normal commensal for the rest of us, this can cause issues with their development and developmental delay. And in addition, their preterm babies and term babies are also more susceptible to acute kidney injury, which can have lifelong consequences, and also retinopathy of prematurity, among many other multi-organ aspects. Neonates are different to adults in many ways. Their immune system is different because babies have had to develop in utero, and they have a different immune system to their mother. And both of them have dampened their immune system, so there's no rejection of the baby who's a fetus and allograft. As well as that, we can see they have a decreased neutrophil pool, and they haven't received all the maternal immunoglobulins and antibody production. They can have immunodeficiency at birth and may have been exposed to maternal sepsis and chorioamnionitis. But then, conversely, they can mount a very strong immune response with a cytokine storm in necrotizing enterocolitis. And we don't have a lot of evidence until the more recent past to build on, because immunology relied on large blood samples that were taken from cord blood, but this doesn't really reflect the environment of a baby. And we have found that all these studies do not really reflect neonatal immunology. Again, we know that babies develop their immune system really rapidly after birth, and this is augmented by labor and delivery. Again, maternal sepsis can be a huge risk factor, and we don't always factor that in. What is the maternal microbiome and what antibiotics she's been exposed to? And things that we can do to help babies are we can give them a kiss on their first day and let them cuddle with mom and have breast milk, even if they're critically ill. However, we have to be careful about pathogenic microbiome if their mothers had very severe E. coli sepsis, and we need to protect mother and baby in those conditions. So what is sepsis? The definitions have really come to us from the adults and children. We don't have a universal definition in babies, so therefore it's really difficult for us to benchmark against each other, to collaborate and to put data together. So we don't even have a standardized international management plan for sepsis, and it is even different in each institution across different countries. And it's also different across the world, because in many lower and middle income countries, there's a much more increased incidence of antibiotic resistance, which is causing problems. So we do need new treatments in addition to antibiotics, and we do need more clinical trials, which involve long-term neurodevelopmental outcome and multi-organ monitoring. However, when we look at the way we've studied sepsis, we've looked at different groups. So sepsis is defined in Sepsis 3, which is the adult definition, which they came to, as you can see, after several iterations. And this is the third version. It's a life-threatening organ dysfunction caused by a dysregulated immune response to infection. They don't use the SIRS criteria any longer and focus much more heavily on organ dysfunction, less heavily on inflammatory response, and it doesn't rely on having a definite positive blood culture, just a high risk or high susceptibility to sepsis. They also use a special scoring system called the SOFA score, which is increases in 2 points or more from baseline, and it's at the presence of either a confirmed or suspected infection. So it would sound really simple that we should just use this in neonates. But when we look at the randomized controlled trials of neonatal sepsis, there are 85 different definitions in these trials. And we would have thought that they would have the gold standard similar definitions. They've used criteria such as microbiological culture, clinical signs, laboratory parameters, and some measure bacteremia and some measure sepsis. And there is a lovely new neonatal SOFA, which is here developed by Jim Wynn. And this can be very useful and has been validated in preterm babies in multiple settings as a marker of mortality, and has potential use within definitions and diagnostic criteria in the future, but again, it's not consensus-based yet. So what we decided is we would try and build a definition as a very simple sentence like Sepsis 3, and we created the Diagnostics Consortium defining neonatal sepsis. And we did those systematic reviews and reviews of other definitions to do this. And then we assembled a steering committee, including parents and families affected by sepsis. And we have had ongoing meetings to develop a questionnaire to be sent out globally. At the moment, we have created a real-time Delphi questionnaire based on those parameters we took from the 85 definitions from RCTs. And this is just being put out online. And soon we will be asking you and inviting you to be part of that in the near future. We will have consensus meetings which following our Delphi results, where we're going to work with the James Lind Alliance to produce consensus with including different countries, different languages, with parents and people with lived experience, to make sure we come up with a sentence or several sentences that encompass what we think sepsis is, so then we can further move on to do diagnostic criteria. We've published our protocol paper that you're free to read here. It's in Pediatric Research, and we did previously worked on core outcome sets for neonatal sepsis. So we have then, when we looked at our other definitions, we also found, looking at epidemiology, like Vermont Oxford Network, there are 128 in total, all completely different. So we are now working on the real-time Delphi. What's difficult as well is in sepsis, it is constantly moving and dynamic. So it is like trying to hit a moving target. And that's what's made it so hard to define. And it has many implications for therapy, as many trials mentioned here, especially in adults, have not worked because we've assumed that everyone is at the same stage of their sepsis at the same time. So we do need to create individualized, targeted, biomarker-led therapies, and we can learn from the COVID studies like the recovery trial and from many oncology trials. And new studies like the NANO study looking at antibiotics and empiric antibiotics are going to be really helpful in this area. There are many potential therapies studied, but again, many of these may have used different definitions, and we may be able to find defined patient populations that these will work for. So what we're working for is to create a new definition that everyone will use, so that we can go from untargeted therapy to personalizing and stratifying patients ultimately, and stratifying our definition. So what's next is, I suppose, we should have national data and create management guidelines. And I just wanted to announce that we've started to establish a Newborn Sepsis Society, and please get in contact with me if you're interested. And we're going to be meeting at the end of the week in Boston at the Pediatric Academic Societies meeting, and we'll start to advertise this. And what we say, what can you do now? Know what's happening in your institution, know your biomarkers, know your guidelines, and what cultures and what happens. Try to start your antimicrobial stewardship. Look at what's happening with maternal investigations. And then can you please join us and collaborate in our sepsis societies and ultimately answer the Sepsis Delphi so that we can all work together in coming to a new definition. So thank you very much for listening, and thanks to everyone who's participated in this.
Well, thanks to Eleanor for a really wonderful presentation. As you know, it was a recorded presentation, so we're not able to take live questions. And we are at the end of our time. In fact, we're 5 minutes over, and still I'm really pleased to see that there are over 130 of you online joining us for this really fascinating set of talks and discussion. Over the course of the last hour and 15 minutes, we've heard from investigators and scientists from India, South Africa, as well as the European continent, who are speaking about the challenges and the burden of neonatal sepsis, particularly in low and middle income countries, the need for better approaches to prevention, the need for more systematic assessment and evaluation of treatment options so that we have more data-driven approaches to treatment options that are associated with reductions in mortality, and thinking about overall the definition as well as the diagnosis and prognosis of infants who are at risk for poor outcomes, and thinking about the appropriate diagnosis and definitions of sepsis. So thank you so much to all of our speakers, and many thanks to all of you for joining us in this wonderful session. I think we can recognize that making progress and getting to impact in our shared goal of reducing neonatal sepsis and improving neonatal mortality metrics and reducing neonatal mortality overall will take a joined approach and will require all of our efforts. So thanks once again, and good morning, good evening, and good night to all of you.
Nice. Well done. Thanks, everyone.
Thank you, everyone.
Thank
That was
you.
really
Bye-bye.
great.
Thanks,
Bye-bye.
Padmini. Great. Thanks. Bye.
Yeah, thanks all.